So today what I want to talk to you about is the strategy by which we're doing this. And it's essentially trying to use blood tests to get better at understanding what's going on inside a tumor. So I think, as you guys know, there's an increasing number and type of potential therapeutic options for aggressive or metastatic kidney cancer. That's not to say they're necessarily approved, but there's a lot of research sort of proposing novel ideas and novel targeted approaches. But the reality, looking down the road, is that most of these therapies will not be effective in all patients. So, that creates a dilemma because if you design a clinical trial to test a drug in all patients, it may well not be positive if it's only going to be successful in some patients. So how do we move forward from this? How do we move to a framework where we can maybe more precisely use a drug by only giving it to the patients where it's actually likely to work? I like to show this slide when I talk because I think it illustrates what we're dealing with from a cancer point of view. So this is what happens if you line up your chromosomes from a single cell in one of your normal cells. So you guys may have heard that we have 23 pairs of chromosomes, and this is kind of what they look like down a very, very powerful microscope if you line them all up. So that we can tell this is a man because he's got one X and one Y chromosome, and you can see he's got 22 other pairs, 23 pairs of chromosomes in total. This is what a very advanced cancer cell might look like. Now, this is not actually a kidney cancer cell, but the point is that you go from here to here, and what you've got here is a huge series of changes and mutations and what looks almost unrecognizable from before. So what you can imagine is what cancer essentially is at its base level is a disease of your DNA. And so what's happened here is the cancer cell has lost a bunch of genes that's stopping it from proliferating. It's gained a bunch of genes that it can use to live somewhere else in your body and so forth. And so it's sort of adapting to its new role. And so, but you can imagine that this is just one possible outcome, and there are many, many possible outcomes. And so that kind of gives you a sense of why each cancer is different, because there are many, many ways that you can lead to a sort of aberrant, rearranged genome. And so that's the point I'd like to emphasize here, that the exact mutations, the changes that you get to your DNA, they differ between patients. And so even though what you have in the end is a kidney cancer, it's actually the cancer has taken its own route to get there. And so your own cancer, or from in any disease site, is really unique to the person that has it. And that ultimately governs why some patients respond better to therapies than others, because the underlying cancer itself, whilst it is still kidney cancer, is mostly unique. So obviously, there are sort of key features that cancer cells gain, and the mutations allow them to do this. So perhaps allowing increased blood supply to the tumor is a pretty fundamental thing that a cancer needs, and there are many different mutations that can occur that would lead to that. So why bother understanding all this? Why is this useful? Well, it's because if you have a very mixed patient population, if you use, let's say chemotherapy in this population, you're really not, you're sort of applying it indiscriminately. And so one sort of model for improving the way that treatments are given is to better segregate populations into the subgroups based on their genetic changes. And so that's really the concept of precision medicine and precision oncology, and something for the future that we're all trying to work towards. I'm going to show you a very complex slide now that's not intended to be understood, but it's to give a sort of idea of what's going on. So what has happened is groups all around the world have studied the DNA changes in hundreds of people's cancers. And they've done this by taking kidney cancer tissue samples from patients and subjecting them to sort of advanced profiling techniques. And what we're able to do is actually build up a picture of what genes change on average across all different patients. And so we can use this to sort of build up these fingerprints and look for commonalities between fingerprints. But the problem is, that's all done in large academic centers. It's done using tissue. It's done normally using primary tissue, that is the cancer that's in the kidney, rather than, say, a metastatic lesion somewhere else in the body, which is what people die with or of in the end. So what we've got to do is get better at understanding that metastatic disease, because if we really want to treat the metastatic tumors, we have to understand them too. So how do you actually get real-time information from patients with metastatic disease? So it's not really clinically feasible, and it shouldn't be desirable to be going in and taking invasive tissue biopsies from patients just to do research. So that's where the concept of the liquid biopsy comes in, and what my laboratory focuses on studying. So it's the concept that tumor material, that is tumor cells, pieces of DNA, and other material from cells, is shed into the bloodstream by proliferating cancers. So technically, in a small vial of blood, you have information from the tumor that you could capture and study. So this is actually not a new concept, and I found this this article from 1869, which is a pathologist called Thomas Ashworth, who looked down the microscope at a blood sample from a patient of his who just died of cancer, and noticed that there were cells in the bloodstream that looked very, very similar to the cancer itself. So the problem is, even though these were recognized over 150 years ago, we didn't have the technology to study this material. So the key now is we do have that technology. We can take a blood sample and identify those very rare cells or DNA molecules. Despite all the hundreds and millions of normal blood cells and normal DNA molecules, we can identify the tumor component within that. And so this is a very elegant picture of where we are now, is in the concept that we can take a blood sample, and from that blood sample we can identify what we call ctDNA. So that's circulating tumor DNA in the bloodstream. So it's DNA shed by the tumor that's now present in the peripheral blood. And we can subject that tumor DNA to a barrage of technological tests and analysis to actually understand what those specific and unique mutations are that I referred to earlier. So we can use this circulating tumor DNA as a window into the metastatic tumor itself. So what's the implications of this? So, there's a lot of excitement at the moment about early detection of cancer, because if the circulating tumor DNA is detectable in a blood sample from a patient who seems otherwise healthy, it might indicate that they have an early stage cancer. Similarly, if you can still detect tumor DNA in a patient post-surgery or post-therapy, then it might indicate that they still have cancer somewhere in their body, and you could intervene perhaps earlier than you might otherwise. From my point of view as a researcher, I'm very interested in this later setting. Well, how can we get better at understanding metastatic disease and treating metastatic disease? So I think what's very exciting is circulating tumor DNA has the potential to give you information about all of those tumors simultaneously. But what we've got to do first is prove scientifically that this is useful and feasible in a sort of practical and clinical setting. So in prostate cancer, over the last couple of years, I've been very fortunate to work with some outstanding researchers in Canada and British Columbia and publish a wealth of articles showing that using this approach in metastatic prostate cancer is very representative of using a tissue biopsy and gives us a very good idea of how patients are going to respond to different therapies. And we've been able to show that the information that we get from a blood sample is virtually identical to what we get from a tissue. So this nice plot up here, it sort of doesn't really matter what it represents, but you can see that the top and the bottom are very, very similar. The top is from a blood sample, the bottom is from a tissue biopsy. And in fact, this is my close friend and collaborator, Dr. Kim Chi of the Cancer Agency here, presenting on our work at the American Society of Clinical Oncology this summer, and how circulating tumor DNA can help guide the use of therapy in prostate cancer. Here's just one case example in prostate cancer of where a patient who had liver metastases, we profiled his blood sample and found something which might suggest sensitivity to platinum-based chemotherapy. And this patient subsequently exhibited a remarkable response to platinum, and 2 years on is still responding. So we expanded this approach into bladder cancer, and I've been fortunate to work with Peter Black and Bernie Eigel and be funded by Bladder Cancer Canada to explore this concept of circulating tumor DNA in bladder cancer. And we published this summer our feasibility study showing that, remarkably, the same thing seems to be holding true in bladder cancer, that circulating tumor DNA gives you a window into metastatic disease. So what about kidney cancer? So there was a really great study published by a Danish university actually this year, who demonstrated, sorry, not a Danish university, that's bladder cancer, a US university that showed that circulating tumor DNA is also very prevalent in patients with kidney cancer, and that actually we can use it not just for screening in the post-surgery or post-treatment setting, but also to give that window into metastatic disease. So, what are the next steps? And I think it's to develop circulating tumor DNA to help guide precision oncology and to form a tool for metastatic kidney cancer. None of these things are magic bullets. The way that we see it as researchers is that there are a wealth of tools currently available to clinicians, including clinical tests, blood tests, imaging, and so forth, and sort of an understanding of the genomics should form part of that toolkit for making decisions. It should never be something that surpasses clinicians' opinions and experience. But what we seem to see from our early studies is that most metastatic kidney cancers have abundant levels of tumor DNA in their blood. And actually, it's possible to detect unique alterations that could prompt consideration of non-conventional therapies. So that is, we can see changes to DNA that are targeted with drugs in other cancers. So the concept being that perhaps they might be therapies that are suitable for bladder cancer. So we can use this information in the future to help design trials to help us move those therapies into kidney cancer and into this realm. As an example, this is what we're trying to do in prostate cancer, which is take patients, screen them all for their circulating tumor DNA, and then based on their tumor DNA signature, their fingerprint, stratify them on different therapies that are not currently approved for prostate cancer. So I can see a situation where this approach would be very beneficial and worth trying in kidney cancer as well. And so again, I've been lucky to team up with Christian and with a fantastic fellow called Lucia to apply this concept to kidney cancer. And so our goals are to expand to a cohort of kidney cancer patients, to apply the approach that we've developed and tested in both prostate and bladder cancer, and use that wealth of experience to actually understand why kidney cancer patients are responding to therapies and potentially other therapies that might be effective. So these are our immediate aims at the moment, and what we're testing in the laboratory as I speak. So as I mentioned, we're expanding to a large cohort of patients from across British Columbia and Canada. And this will help us understand how to design the next wave of clinical trials to bring more therapies into the realm of kidney cancer. We're going to establish circulating tumor DNA as a reliable tool by comparing to matched tissue biopsy and show that it does everything that a tissue biopsy can do, we hope. And we're going to identify which mutations, which changes in the DNA correlate with response to all our existing therapies? Because that's very valuable information to understand as well. It's as useful to be able to say that a therapy may not be effective and therefore a patient can avoid the potential side effects of an ineffective therapy as it is to nominate successful ones. And I would emphasize again that all this, what we're really trying to do is do this within a clinically practical framework that requires only a blood sample and can be done routinely in any clinic across British Columbia. It doesn't require a complicated machinery at the point of collection. Blood samples can be sent in the post and just analysed by my laboratory. So with that, I'll just say thank you very much for listening. I think we're going to take questions at the end. In particular, I would like to thank all the patients and their families that are contributing to these studies. Obviously, none of the research we can do without you guys and without the bladder and prostate patients too. But also to Bernie, Kim, Christian, and Alan, who are supporting me in my research in Vancouver. So thank you very much.